My name is Courtney Coble. I'm Executive Director of the North Dakota Medical Association. And the North Dakota Medical Association is opposed to House Bill 1254. I have uploaded my testimony. The printed copies are out there too. Our NDMA policy forum recently passed a policy statement that NDMA should take all reasonable and necessary steps to ensure that evidence-based medical decision-making and treatment exercised in accordance with evidence-based standards of care does not become a violation of criminal law. This bill does that. I'll just say me too for Melissa's testimony. I couldn't agree more. We are very concerned about interference with the patient-physician relationship and the legislature getting involved in medical decision-making. There's physicians and psychologists here to testify after me, and they'll testify as to the exact details on how this treatment gets conducted, different side effects, etc., and why patients would be harmed if this was made a crime. We recommend a do pass on this bill as it sits before you. However, I did attach an amendment, and that's also at your table, also uploaded. And I'm going to try to just quickly explain this amendment, and it might not be perfect, and I would be more than happy to work with the committee in further days. What it does is create, using the medical standards of care, the amendments would prohibit any hormone treatment prior to, the term is pre-pubertal child, a child before they enter puberty, no hormones before that, and then no surgery under 18. It creates one more definition of pre-pubertal, and then it goes through dividing up the statute in that way. But that's the overall intent of the amendment. And as you'll learn, no genital surgeries done on children in our state. And I would then just point you to the back half of my testimony, which is a list of all the people that are going to come after me. And Melissa introduced Dr. Danielle Sturgill, but Gabrielle Belf is here. She's an NDPS and NDMA member. Then Amanda Dahl, Louis Cassis, and then online we have Rachel Peterson and Mason Bedient.
And to make sure, just to make clear, that the NDMA would be supporting this with your amendments, correct?
That's a tough question. The bill is a lot better with these amendments.
Well, then
we would prefer, because it still would have some criminal things that we don't do, and it's not accepted medical practice. So it makes the bill enormously better.
How does it currently work for minors receiving medical care? If they're a minor, do their parents have to sign off on that currently for other sorts of medical treatment?
I'm going to have to defer that as to what that they would do. On a personal note, my daughter has a genetic high cholesterol. She was 16, and we tried to find a pediatric endocrinologist. None in Bismarck. We drove to see Dr. Cassis. And so a bill like this passes, and I get afraid for our state that we're not going to have these medical specialists, because pediatric endocrinologists, yeah, they do trans care, but they also treat diabetic kids, high cholesterol kids. We need them to be here.
My name is Gabriela Balf. I'm currently a psychiatrist in Bismarck. I worked as an internist for 9 years. I did both residencies in New Haven, Connecticut at Yale School of Medicine. I have a master's degree in public health from Yale School of Public Health, and I'm associate clinical professor at UND. Although I have many hats, I speak today on my behalf and on my psychiatric societies. I have prepared a separate text that contains the main points of my testimony today, which briefly would be that the transgender condition is a real medical condition, that we have recently amassed a lot of information about its biological causes, and I will review some brain imaging data. And I also brought some props. Transgender healthcare is a thorough medical process that's sanctioned by decades of research and massive data gathering. There are severe consequences of not respecting the medical standards and overwhelmingly positive consequences of providing this care. First things first, let's be sure that we have all the same terms. I only have 3 slides. This will be in terms of terminology because I saw a bit of confusion earlier. So genitalia gives you the sex, and sometimes even that is ambiguous, like my colleagues in endocrinology will point out. Identity is you identify with in your brain. Attraction, which has been a confusion earlier, is who you're attracted to. This will be the heterosexual, homosexual, pansexual, meaning that you were attracted not to everything on the planet, but basically to people of other sexualities. We're not talking bestiality here. And expression is the outward way of showing our gender identity. Next, I will not go into the sociological, anthropological, philosophical definitions of what means to be a woman and a man, and therefore, because this is way outside of my expertise. However, in terms of recent development in science, we know something about men and women that are making a fundamental difference. Some people, when they're asked, how do you know that that you're a man? How do you know you're a woman? And we're all caring people, men and women. This is not an advantage to women alone. But we can all have sense of leadership. This is not an advantage of men only. My husband is definitely a better cook than I am. And I am the one who fixes the computer when it's broken. So these variations are not what would mean differences. And within womanness and manness, there are a lot bigger variations than would be within the sexes in the legal sense themselves. However, in terms of neuroscience, this is a critical difference that has been detected, which is men are like waffles, women are like spaghetti. Someone put it. Basically, what it means. So if you have these hemispheres, as you can see them pointed out, men are very compartmentalized. So they have intrahemispheric connections that are very strong. And you'll see that when men decide to talk about the topic, they go through it thoroughly and they don't wade like I would. Now, women, we use both our hemispheres and actually our corpus callosum, which is the white matter that links the two hemispheres, is a lot thicker in women. So
Is that what makes us better at multitasking? I was hoping
let's
she'd
put
say
it
yes.
this way. You won't get simple answers from me
Of
because
course not.
I'm a
love it.
psychiatrist and my favorite answer is it depends. But definitely we can use our brains in the same situation, both hemispheres, a lot easier than men could. Men get locked into one easily. Now, in terms of transgender condition, this is something that we know now since 2015, that people who identify as females, even though they have the external genitalia of a male, they do have very thick interhemispheric connections. So basically, their brain looks like a woman's and vice versa. This is very important. And some people ask me, why don't you just do this kind of functional MRIs on everyone? The answer is this is very expensive. I really do hope that in the future we'll be able to afford to do that. But for now, not even genetic testing is widely available. And did you know that there's no FDA approved genetic test yet? So we are way behind in science. However, we do have some explanations available that we can bring forth today. The medical term of transgender condition is gender incongruence. This is a medical condition, is not a mental illness. This is a condition that's akin to a congenital malformation. Like some people have hearts that are really messed up, and my husband can explain this better. He's a cardiologist. And even though they're born with this, we will still go forth and address those when children are small because they're life-threatening conditions. Now, the mental distress that some transgender people experience when they have this gender incongruence and society doesn't accept them, that's called gender dysphoria. And that can have the appearance of a depression, anxiety. However, it doesn't go away with the treatments we know work for depression or anxiety, which would be psychotherapy medications. So mental distress plus non-affirming conditions. Why do I say that? Because there are some societies where you do feel that you have the wrong head for your body. However, you don't become distraught over it. The society has no problem with you. There are plenty of examples I can give you in other cultures. And therefore, you don't qualify for this diagnosis. It's not a mental illness. This gender dysphoria is in this short version of the DSM. And some speakers earlier made some confusing statements in that there will be other parts of dysphorias or it will be body dysmorphic disorder. And I'm just saying that as a doctor and as a scientist, I take these things very seriously. When I make a diagnosis, is not only checking some boxes in this, I also see what else is going on in this individual, adolescent in our case. And I also see what is not there, which would be the body dysmorphic disorder or some sort of delusion psychosis, because that would require a different treatment.
So you said gender incongruence and then now gender dysphoria. Are those two different things or two different ways to say the same thing?
They're two different things.
Okay.
So gender incongruence is the reality of having a brain wiring that doesn't fit the genitalia. If you're in a society that gives you a hard time, you can develop gender dysphoria,
Okay.
which is very
So that's when you
distressing,
add
and
the
that's the
distress.
mental
Okay,
anguish.
thank
Yeah,
you.
Thank you.
Thank you for clarifying.
Now, other misunderstandings numbers that I would like to clarify were regarding the timeline, and that's why I brought my last slide, where is on average what goes on throughout these children and adolescents' lives. So what I wanted to point out is that most kids will form their gender identity early, but some experiment with gender ideas later. And it depends on the studies. These reviews are immense. There are dozens of 10,000, 22,000 people in just one study, and you do meta-analysis of a lot of studies of this magnitude. So you will find out that a lot of these kids will change their mind by the time puberty hits. This is where in our state is around age 12. They have to be 10 or 2. We don't treat that. Even if they have this mental anguish, they qualify, they get to the point of gender dysphoria, we do not treat that hormonally or surgically. This is the population that a lot of speakers before talked when they said, oh, these kids are changing their mind. Yes, children do. Very different stories about adolescents. The adolescents who grow once puberty hits and they see, oh my gosh, this is what's going to my body, and the body changes, and they get more and more distraught, and they qualify for the gender dysphoria diagnosis. All these adolescents, 99% and more, Dr. Casas is very well aware of the numbers, they will go on and will need treatment to get this anguish addressed. This will not magically go away. This slide that I'm going to ask you to keep in mind for later will also show that we don't do genital surgeries under age 18. Like it's been said before that we do castration mutilations. This simply does not happen, nor do we administer puberty blockers or any other kind of sex hormones before puberty hits. Why is that? One practical reason, for instance, is that later on, let's say this kid goes through this whole process, which is very arduous and very long, they actually need some material to make these new genitalia. Oh, no, we don't cut off anyone's penis because we need it as a material for later on. So all these processes are taking a long time, thorough assessments, and my colleagues will talk about these practical issues later. I just wanted to bring to your attention the very concrete misunderstandings that have been put forth. Last idea that I'm going to bring will be that during adolescence, there are some irreversible changes happening to the bodies as well. So if we say, well, let's wait until they reach maturity because they're now confused, not providing gender-affirming care is an active choice. And in my practice, I've seen kids who saw with horror that their voice is deepening. They get Adam's apple seems to be very, very upsetting to quite a few. I saw a kid who whispered the whole year. So from top of the class, got to be this shy, completely facing, disappearing into walls kind of person. Dysphoria is not simple sadness, is so severe that kids cut. Kids harm themselves. They start using substances to make this anguish go away. So not acting on this is an active decision that has very severe consequences. I will not put these forth because all these numbers are provided in the papers I gave you. I will just bring the concept of minority stress, which is pertinent to what we're doing here now, is basically having a condition and around the family unit, the society, and then the whole structural environment around them that contains institutions, state policies. They all contribute to this minority stress. And when coping is maladaptive, then you get psychopathology. In itself, the condition would not result into these tragic examples that you can see. We all thank you for the opportunity to bring our experience section and our organization's recommendations to treat, and we urge you to consider the amendments. We do not agree with this bill that has language that criminalizes and, frankly speaking, insult us. However, out of two evils, keeping the amendments in mind may be an option. So thank you, and I stand for questions.
I get the steps, and you and I've asked you many questions because my brain still just I'm struggling with this because there are parts of it I agree with it, and there's parts of it that I just don't know. Meaning the standard of care and then the bill. I have a lot of conflict within me, and so if you can talk to me a little bit, and maybe you want to put this off for Dr. Casas, but help me understand the puberty blockers because I'm a nurse. I get medicine. I really struggle to understand how they are reversible because it feels like Like, just if you're fighting your body's natural process, there has to be some consequence. And then my second question is there anything within the standard of care that says, you know what, we will not give blockers or hormones if you're not also pursuing psychotherapy, supportive, that kind of stuff?
Let me tackle the second question first because that's the easiest. Nobody will institute blockers, hormone treatments without having been evaluated, be monitored by a mental health person. That's a no-no. When we refer for treatment or for surgery, mental health is involved, and surgery actually is after age 18. So we're not talking about this population now. This is exactly what we need, a pause button for them to think about it, because this will take months, years, and we need to have this time to think it through with the mental health people, with the family. Sometimes the families are not all on board, so we need to bring everybody in consensus, because otherwise nobody's going to treat the kid if the whole parental consent is not obtained and such. So we do need this space to think these through, and puberty blockers are bringing, and Dr. Casas, I'll let him speak about the biochemical part of it.
My name is Dan Sturgill. I'm a clinical psychologist at Sanford Health Fargo. I am wearing two hats today. I think I'm going to start off by focusing on my hat on behalf of the North Dakota Hospital Association, which represents the hospitals and healthcare systems across the state, and representing that testimony against House Bill 1254. I respectfully ask for you to give this a do not pass recommendation. I'm going to go ahead and go through the majority of this. I'll skip one paragraph. If you need me to come back, please do. But I'm really hoping that people will ask me questions. North Dakota needs to be a state where parents and families are free to pursue the best possible health care for our youth. As a clinical psychologist, I have firsthand knowledge of the seriousness of gender dysphoria. It's a health condition where a person's internal sense of gender is inconsistent with their body experience. Patients frequently express a sensation of being born into the wrong body. It's a condition that can begin at an early age, but frequently intensifies at or around puberty. For those of us who have never had to endure this painful situation, it is hard to fathom the way that this can negatively impact every aspect of a person's life, and I might add development. Over the last 30 years, significant research has been conducted on alleviating this condition. Initial efforts at changing the mind, conversion therapy, have been unsuccessful and dangerous, leading to increased depression, functional difficulties, and increased risk for suicide. We have come to understand that gender dysphoria can best be addressed by bringing a person's body experience into alignment with their internal identity. For many, this may involve just a social transition. I'm aware of many individuals who have had success with just this social intervention. For others, the body dysphoria is best relieved with positive changes to the body. Prior to recommending any gender care, a thorough assessment is required. This involves parents, mental health providers, medical providers, and others. A number of domains have to be addressed, such as history of trauma, other mental health conditions, experiences with the internet and other media, social experiences, attitudes towards gender stereotypes, experiences with puberty, emotional and intellectual maturity, decision-making ability, and thoughts about emerging adulthood. If there are any areas of concern that emerge, these are discussed with parents and team members. This can lead to recommendations for other services rather than gender care. In some cases, we encourage the youth and family to explore other options for relieving this distress. Only when other alternative interventions have been explored would the team move forward with gender-related interventions. Then skipping down to some summary statements here, when it comes to youth care, healthcare providers have an obligation to follow best practices when they diagnose a medical condition. Every intervention meets the standard of medical necessity. To withhold such treatment would be malpractice. I have personally witnessed numerous examples of youth improvements in dysphoria, academic functioning, social functioning, and overall well-being following proper administration of medical interventions. These improvements last into adulthood. Patients that are not afforded this treatment in youth experience a variety of challenges as adults: increased mental health problems, lower economic status, social problems, increased substance use. Current standards are being followed to rule out conditions or situations that could be better treated by other means. These decisions are being made with multiple providers, each of which brings specialized expertise in the decision-making process. There is a careful process of weighing the risks and benefits and sharing this with parents and youth. A couple of things I'll reference that I think got scanned in is kind of a quick reference on gender-affirming care in general, with some references attached attached to that. And then also I wanted to make note of a letter to the editor that was sent to a number of newspapers that is signed off by a little under 200 providers and a number of organizations totaling over 200 endorsements. The thing that was really exciting about that for me was seeing that there were people from all of those multiple disciplines that participate in this care involved in signing off on that letter. I hope that sends a strong message. I'll take off my hat for a second and be Dan Sturgill, the psychologist. A couple of things I wanted to mention about this morning. The issue of suicide can be a very confusing one. And one of the things that I want to assure you is that because of the minority stress, because in our culture it is very difficult to go through life with a different experience with your body than your assigned sex, there is an increased risk for people to either have suicidal thoughts, consider suicide, attempt suicide. And when we're looking at the literature, some of these different publications define that differently. There aren't actually a lot of publications that look at completed suicides. We have quite a bit of evidence for attempted suicide. So sometimes there's some confusion there where people say it's not necessarily associated with the suicide completions. But as a clinician, I will tell you that my experience has been a very typical experience, is to meet with a family and have them tell me the story of how they, a lot of times around the time that they came out, that there was self-harm, there were attempts, that there were psychiatric hospitalizations. And only after that youth began to receive affirmation from the family, from friends, from the school, is when those thoughts and those attempts stopped. And I was reflecting on some of the research as well. When people are put into research groups, these are going to be individuals that have been identified in some way. And so taking a look at what the, suicide attempts have been like for people who are starting treatment is very different from people who are just beginning to be identified. So as a clinician, I can tell you that this is saving lives for people to get involved in this care. Another thing that I don't know how much time people want to spend on this, but every European country is providing this care. There's a lot of things that are involved in that, but every country recognizes this, a European country recognizes this as important care and has some kind of a national health care way for youth to get services. There has been some things that have happened in Sweden where some reviews were made coming to some conclusions about the evidence, but care is continuing to happen there. And there is a lot of bulk of evidence saying that there is sufficient evidence to proceed with this care. One of the things that I think differentiates this in some ways is that we have a lot of evidence for adult care. And so the thing about this kind of care is that the time when it's very important to intervene, the time when we can really turn somebody's life around, is when they're young. Because a puberty process that does not match with your sense of self is quite frankly dangerous. It is extremely uncomfortable. It puts you in a situation where you're going to be developmentally behind your peers in many ways, socially behind, dealing with the minority stress that's related with that. So although I will admit that we don't have as much of a history, we only have since 1998 in terms of working with youth, and we're going back to the 70s with adults, we can apply some of the same ideas and concepts from the work that we've done for many, many decades. And we have information following a group from 98 and then looking at them again in 2014. And also I'm really proud of where this care is right now, because I think the problems that have occurred have been related to providers that haven't been following standards. And what we're doing here in North Dakota is really following the standards. I'm really proud of the people that we have. You're going to be hearing from some really great individuals. I think all of us have gotten into this work, and actually I'm going to steal something from David Newman, who's actually an adult endocrinologist, who when he was trying to decide what kind of care he was going to be specializing in, I'm gonna butcher this story, but he was talking with somebody about, well, what should I specialize in? And they said, probably said, Dave, if you really want to save lives, get into gender care. And so I know that's why I got into this. I saw Alice and Ken Christensen were two therapists that had been working in the area of gender care since like the 1980s, primarily working with adults, just starting to get into working with younger adolescents when they both retired. And when they did, I was like, hey, I want to work on this. And so did a year of supervision with Alice Christensen. Over the last decade, have done a lot of training in terms of getting up to speed with working with both adults and adolescents. And one of the things that's really cool about working over the lifespan is that I've had the chance to see, it's really fun to see somebody who's 68 years old going through a transition process and really coming into their own. And then it's also, fun to see young people who are just maybe going to college or, have just turned 20, 21, and they've gotten into a position where, boy, it was really hard growing up in a rural area, wasn't able to do this, but now I can. And then also working with families who are coming to me with, really dire stories of how difficult it is growing up with this experience. The adults that I have worked with, every one of them has indicated that it would have really changed their lives if they could have had this care early. So this is really important for us to be looking at. And the two things that are really important here in my mind is parents and families working together with providers. That's how we get the best results. And then also following best care practices, which we already are. And so with that, I would yield any questions that you folks would have.
My name is Dr. Amanda Dahl, and I'm a board-certified pediatric endocrinologist who chose to come back and practice in the state of North Dakota. I was born in Valley City and have lived here my entire life, with the exception of the 6 years that I completed specialty medical education before returning back to the state. While growing up in Valley City, my dad was a Lutheran pastor and my mom was a high school teacher. A little bit more about me. After going to college, I then went for 4 years of medical school at the University of North Dakota. I completed 3 years of pediatric and adolescent medicine, and then an additional 3 years of pediatric endocrinology fellowship, both of those which were at Mayo Clinic. I am one of 2 pediatric endocrinologists in the state of North Dakota, and you will get to hear from both of us today. I have the absolute distinct pleasure and privilege of getting to care for all of the patients that I see in the state, and we cover a very large breadth of patients. So to be honest, the transgender individuals that we're talking about, it's a very small part of our practice. So other patients that I get to see have diabetes, thyroid problems, adrenal, there are endocrine tumors, there are bone metabolism problems, any early and late puberty, and then growth. Those are the primary issues. With being a board-certified physician, I follow expert committee guidelines, and for transgender care, that includes committee guidelines that have been established for decades and that are continuously revised to be up to date on evidence-based medicine. And some of those are American Academy of Pediatrics, there's Endocrine Society, and also the Pediatric Endocrine Society that are supporting us with this. As a pediatric endocrinologist that cares for a majority of the transgender youth that we are currently talking about, I have the pleasure of getting to work with a multidisciplinary team like you have heard from my 2 other colleagues. And my testimony is really going to be describing what that looks like. So there are numerous stakeholders involved in any patient that I'm seeing for gender dysphoria. This includes pediatric endocrinologists. We work very closely with Dr. Sturgill and his team. He is a psychologist that is specialty trained in gender care. We are also working with numerous other mental health providers that are helping with the other mental health issues that are typically occurring. We work with primary care doctors, reproductive endocrinologists, and we'll talk about why that's important. And most importantly, right, it's a patient and it is the family members that are involved in this. So our relationship typically is lasting for months, if not years. And it starts when a primary care provider or a mental health provider actually refers to pediatric endocrinology and the gender specialized psychologist. Our first visit is the longest for any endocrine visit that we have. And during this visit, we are doing our basic things that we would be doing for any patient. So we talk about if there are any hormone imbalances. We have a very lengthy discussion with family members in regards to where they are for puberty, because our discussion then changes regarding where they are for puberty. We also are talking about where they are in their transition. And it is really fun to actually get to listen to both the patient, so usually the adolescent, and the family members talk about when they first noticed it. And it is striking to me that there are multiple family members that talk about, I knew when my child was 2 or 3 years old. And right, usually most parents, being a parent myself, it's like, oh, he'll grow out of that. And it doesn't always happen. Okay. There is a huge spectrum in this transition, and some of it can be social transitions only. Otherwise, they are becoming adults and they have completely gone through the entire process that Dr. Balf talked about. For us, it is recommended that before starting any hormone therapy, that the adolescent has at least socially transitioned. So that typically means that when you are going and saying hello to anyone, right, I will say, hi, my name is Amanda Dahl, okay? And so it would be like that person is saying what their name is, and that might not be the name that I was given by my parents. And this is usually happening for at least a year, but to be honest, by the time that a patient is getting to see me, they have been in this transition for many, many years. Depending on their stage of puberty, we really are adjusting our discussion. And just like Dr. Balf talked about, for any prepubertal patient, the only thing we are doing during our visit is we are providing information. We are not discussing or talking about anything. We are not doing anything that day. Once a patient has started puberty, we can then consider potentially doing puberty blockers. There is no point in doing a puberty blocker before that, because the whole point of this medicine is, and I won't bore you with all, in endocrine, we love axes, okay? But the pituitary, and actually right above that, so the hypothalamus talks to the pituitary, which then eventually either talks to the ovaries or testicles. If that, before there are any signs of puberty, that communication is not happening. And so we then are not going to give a medicine that's not going to do anything because the signals aren't happening. And so we are not giving that medicine until the person has shown that they are either making estrogen or making testosterone. We are able to do that two ways, either physical exam. We know that there's estrogen present because there's breast development. We know that there's testosterone being produced because the testicles are getting bigger. For a patient who's born a girl, if they have had their first period, at that point, that individual has fully developed breasts, they already have the hourglass figure, and they are bleeding every month. And for transgender men, these three things are incredibly distressing to them. For that visit, then, we are discussing menstrual management, right? So just like what we would be doing with any cisgender person. Yes, we need to have periods, but they don't have to be awful and painful, and we have ways to help. For a patient who's born boy, if she is fully pubertal, and this is the first time I'm getting to see her, she then has a deep voice, has facial and body hair, potentially a Adam's apple. In these individuals, the most common things are going to be the deep voice, but then Adam's apple. And once those are present, they are not reversible. For those patients in the beginning, one of the things that we talk about is what's called an androgen receptor blocker. And that is, it helps with acne and it helps with excess hair, and dermatologists use it all the time for acne. Okay, so we're using this in cisgender patients. Everything I've talked about so far is 100% reversible. Every medication does have risks, and we talk about those, but that's not just for transgender care. It's every single medicine that I prescribe has risks and benefits to it. Next, the big part is I'm giving a 4-page consent form, but really it's information, and the point of this is to go over what is gender-affirming care if we are to that point. What this goes over is I am specifically giving exactly what changes they're going to notice, because there are physical changes, there are emotional changes, there are sexual changes, and there are reproductive changes. And we go over all of these kind of in excruciating detail. We discuss after starting treatment, how quickly they will notice these changes, what things will get better, what things won't be reversible. But what's interesting is that even natural puberty is not reversible. So every person in this room has gone through puberty. We are the way that we are because we've fully gone through it. Because of the ability that if they've been on gender-affirming treatment for a while, there is an impact on future fertility. And my colleague and I, we do not take this lightly. Every single patient, we recommend having them see reproductive endocrinology to discuss fertility preservation. And the beautiful thing, now that it's 2023, is they have some really great technology for fertility preservation. And it's pretty neat if the patient and family members are interested in that. We then talk about the ways that the medication are given. So estrogen for a transgender female is given in a pill form. Testosterone is intramuscular injections. And again, we talk about the risks and benefits of the way that the medication is given. We mimic puberty by starting with a small dose, and then we slowly accelerate, just like what normal puberty would be happening. We do baseline labs before starting, and then every 3 to 4 months, they're coming back to see us. We are checking labs to make sure that the level that we are getting their testosterone or estrogen level to would be equivalent to what their cisgender colleagues and friends would have. Now that we've talked about that, I want to make clear that before I or my colleague even send a prescription for gender-affirming care, 3 things have to happen. The first thing is they have to be evaluated by Dr. Sturgill or someone in his team, and we are making sure that they 100% meet the criteria for gender dysphoria. There is then a conversation between the psychologist and myself to talk about that individual patient to see, is this person ready to start it with all, because every person is different, every family situation is different as well. And then the third thing that we need is we have to have a consent form signed by the parent. There is no way that we are able to send either of these without a consent form from the parent. And this is why it's numerous visits of talking with them through everything. The other thing that Dr. Casas and I do is adolescents usually know all of this information because they've done their own research. And we we ask for them to sign saying that they assent to the treatment. We know that they cannot consent because of their age, but of all the patients that I see, they know what we're doing and they are so excited about it. The reason why we don't wait until 18, so I've heard that a lot, is let's just wait until someone is 18 years old. The issue is that a lot of the normal effects of puberty are irreversible. Like we talked about, testosterone makes a voice deepen, and the reason why it does that is because it lengthens the vocal cord. Once it's lengthened, it cannot go back. So the voice is already going to be deep. For a individual who is making estrogen, if they are already bleeding every single month, they have fully formed breasts, and the only way that they are going to go down is if they are surgically removed. So by providing them puberty suppression or puberty blockers, we are protecting them by seeing these irreversible effects and then allowing them more time to talk with their mental health providers and gender specialists to try and figure out, is this truly what is happening? My all-time favorite visit in all of my endocrine patients is the very first return visit after I've started someone on gender-affirming care. During my first visit with these patients, so yesterday, for example, I saw 2 patients in the northeastern part of the state. Both of them were return visits. One was transgender female, one was transgender male, and they were both on respective hormones. And it is incredible to me that the first time that I meet these individuals, they have very poor eye contact. They're usually very fidgety. They don't talk very much. They are so uncomfortable in their own skin. When we talk about their mental health, almost all of them have some form of anxiety or depression, usually because of what's been going on and how they've been feeling, and a lot of them have had suicidal ideation or suicide attempts. If we've gotten to the stage where we are able to start gender-affirming treatment, and I'm able to say that to the patient, I'm always able to get the very first smile from them, and they visibly they can start to see the light at the end of the tunnel. The most remarkable visit is the next one after it. So I see them 3 to 4 months afterwards, and they walk in, they're still the same person, but they feel better in their own skin. They're visibly happy. They're able to tell you in the beginning, tell me what things have changed, and they're able to rattle off what's been better. Usually, their mental health has improved, and they have not had any suicidal ideation after that. Personally, in my practice, I've had 0 patients who have detransitioned. The last thing we're going to talk about is we're going to talk about a study that shows the risks and benefits. So this was a recently published article, and the most important part here, and we'll talk about why this is important, is this was 315 transgender individuals, all between the ages of 12 and 20. Average age was 16. All of them were pubertal. So those pieces are very important. This was over 2 years, which is the longest study, and it's a prospective study. We'll talk in a little bit as to why that matters, that it's a prospective study. What they found is that all of these patients were given gender-affirming care. So either testosterone for transgender male, estrogen for transgender female. They were able to statistically and clinically significantly say that appearance congruence, and what that is when someone's physical appearance aligns with their gender, their positive affect and life satisfaction significantly increased, and when their appearance congruence improved, that directly decreased depression and anxiety. The other important clinical finding was that some of those 315 patients had received puberty blockers prior to coming in to be in this multi-site study, and that those patients who had received that, they had a greater appearance congruence and better psychosocial functioning at baseline than those who either didn't have puberty blockers or that were started at a later stage of puberty, suggesting that earlier intervention could have a protective effect. This study is important because this was done through the New England Journal of Medicine, and from an evidence-based medicine standpoint, this is Cadillac or whatever type of high status vehicle that you want to think. It is the best. The reason why it cannot have a parallel arm, okay? So we cannot do this with placebo in this particular study. It would be like, so it is 100% unethical to do this type of study with transgender individuals, some of them receiving care and others not. The reason why it's unethical is because, here's an example. I have type 1 diabetes. I was diagnosed when I was 8 years old. If they would have done a study on children with type 1 diabetes, only half of them get insulin, the other half don't get insulin, you are going to kill the people without giving them insulin. So it does not work to do these types of studies, but having a prospective prospective study. It is incredibly powerful and over 2 years. If this bill passes, families and patients, they are going to seek gender-affirming care elsewhere. They're going to have a large exodus of families, or these families are going to go to the black market to get testosterone and gender-affirming care, unfortunately. Also, by removing doctors' abilities to follow these established standards of care, you will drive some physicians away and you're going to impede recruitment back to the state. HB 1254 proponents say this bill was created to protect children. I would very strongly disagree. The medications I use to help those experiencing with gender dysphoria are the same medications that I use to treat numerous other conditions related to hormone imbalances. And Dr. Casas will actually describe that a little bit more. It is evidence-based that I was trained on. Denying patients access to the life-saving care is an unnecessary state law that will take away hope from the patients that I serve. Those in favor of this bill are discriminating, in my opinion, against transgender individuals. And coming from a family of faith, science helps to see what God created, and God does not create junk or mistakes. He doesn't. Please listen to the science that has been proven to be effective for these individuals. Thank you for allowing me to speak and for all of your important and valuable time in this matter. I trust that the North Dakota Senate will do what is best for the state, and that means opposing this bill.
If you can maybe answer my question that your previous colleague
Yeah.
said he'd push off to you. So help me understand puberty blockers. Like
Yeah.
I'm a nurse.
Yeah.
I
Yeah.
get some science, but this
Okay.
one just baffles my brain. I can't wrap my head around it.
Can I ask what specifically you are worried about, or
No, it's not.
what doesn't make sense?
I don't understand how it you're fighting your body's natural response,
Mhm.
and so when you stop giving it, your body just takes over. Like
So, our hypothalamus is making these signals called gonadotropin releasing hormone. So that's hypothalamus and pituitary that are doing that. When normal puberty starts, there is a pulse that starts. So in everyone that's in this room who is pubertal, right, our body is constant for puberty. In the very beginning, those two signals, it's there, so it pulses. So it's there and it's gone. It's there and it's gone, and it's there and it's gone. Eventually, the body is just doing it, and this is how we're all able to do and have babies and those types of things. For a puberty blocker, so what it is it's actually a gonadotropin releasing hormone analog. So it's not an antagonist.
I was
and
not
so
ready for that word.
yeah.
Okay.
And so what it does is it actually makes a constant. So there initially is a brief stimulation of the pituitary talking to the gonads where it kind of makes it go all out, but then the brain gets confused and it goes back to sleep. So then the signals are not happening anymore. So you are not giving antagonist, you are actually giving an agonist, or something that kind of
Fake
initially.
out. So then when you stop it, then the
Yeah.
brain goes, wait a minute, something's missing here. I'm going to start
And
this
then
process again.
And then it takes a certain period of time, and right, so every child is different for when that restarts. But then the body, because the pituitary is still healthy, the gonads are still healthy, then it goes back to talking again. We use this medicine all the time for kids with central precocious puberty. So there are kids, for example, that can have brain tumors, and that messes with the pituitary. And at 2 years old, they are already starting to show signs of puberty. They have boobs, they're starting to have periods. We use that exact same medicine in those kids. I have numerous kids that I'm using it for.
So then now my body's started, is it an accelerated response then?
Nope.
It's like
Goes back to
puberty
what it was
takes
doing before.
the same amount of time from
Yeah.
start to what it would have if it was 2 years ago.
Yeah.
How long are people on puberty blockers in general? Like what would be an average? I know nobody's the same.
Yeah, I don't know. I would say a few years. Dr. Casas might be able to
Okay.
give. I would say a
And
few
then are you on
years.
puberty blockers and hormones at the same time, or it's one then the other?
So it depends. So again, right? Yeah, that's kind of the magical. It all, yeah, right? It all depends. It depends on what stage of puberty, honestly, the person is on. Yeah, it all.
But if you got in right as they kind of flip to Tanner stage 2, then you do one, then go to the other, or is it people who are further into the process that you might have the overlap?
Right.
Okay.
Also, if they're further along in puberty, we might be doing more of like the menstrual management, right? So to try and help the bleeding go away, and then doing testosterone. So those two, I would say, more commonly overlap.
Do you feel like the volume has increased? You know, we're hearing about it so much more. And you would imagine that that also means that people are possibly feeling more comfortable coming out earlier. So, and then I always hear about people talking about the contagion effect as well. So like, help me understand, like from a volume perspective in North Dakota, have we had a relatively flat line or a mild increase, or is that the spike that it feels like it is if you're just looking at the media?
That's a hard question for me to answer. And my reason for saying that is I have been in practice for a little less than 2 years. There is also 2 of us to cover the entire state of North Dakota and the western part of Minnesota. And so we have a large volume of just endocrine patients in general. I would say it's similar to what it was during training for me. I don't know that there is a large uptick, but Dr. Casas, since he has been practicing longer than me, he might have a better answer.
Because of this concern of younger kids and more kids saying that they think they're transgender, do you see many children under the age of 12 or pre? And what do you do in those kinds of cases?
Yes, we have a few. Any referral that Dr. Casas and I get, if they're under the age of being in puberty, we usually say, there's no real reason to come and see us because we're not going to do anything yet. Yeah. Some families really are interested in the information. So if they're coming to see us before they are pubertal, the only thing that we are doing is we are providing them with information as to the process once we get to that stage of being actually in puberty. Other than giving information, we do nothing.
Do they come primarily because the parents have the concern or the child has the concern?
I would say, in my experience, it is usually the family who is wanting more information about it.
It's just information.
Yeah,
it's
it is
primarily
more information, and that the kid usually, or for sure adolescent, they have done their own research. And they would we all know all the lovely things you can find on Google. Yeah. They're primarily, I would say, it is the parents coming for more information.
You'll be happy to know she actually did most of my testimony. So mine is actually going to be very brief. And I'm just going to fill in some gaps and some misconceptions that I think I've heard throughout the day. My name is Louis Casas. I'm a pediatric endocrinologist practicing here in North Dakota. I went to medical school in Oklahoma, did training, a residency in pediatrics, internal medicine, and then also did a pediatric endocrine and an adult endocrine specialty, and ended up boarding in all 4 of those specialties. So, this is what I do for a living. I live hormones. I take care of hormones, and have the pleasure of not seeing just children, but I have the pleasure of seeing children who become adults and continue to see them as adults. So I can see that transition over the many, many years. I want to just clarify a few things. There's one area I actually agree with Representative Tweed and Pritchard, is that 70% of children who experience gender dysphoria do not go on to have gender dysphoria as adults and do not go on to be transgender adults. It is a small fraction. It's only maybe 30%. That 70% we're done with. We're not treating that 70%. And I think that's a big misconception that, 70% we're treating and go on not to have gender dysphoria. That is not true. 70% go on to not have gender dysphoria, so we never have to treat them. It is that 30%. I call it the fork on the road. They feel that something is not right, their mind and their body. And it is when puberty starts, that fork on the road, when they are not developing breast or facial hair, that their distress becomes worse. They are becoming what they are not. And that is the 30% we are focused on, not the other 70% that go on doing what they do. It is in that early stage of puberty where we do start pubertal suppressions. Pubertal suppression drugs like Lupron, they've been around for 40 years, and we've been using in pediatrics. They were approved in 1993 for the use of precocious puberty in children. In fact, 95% of the use of these drugs that we use is not for transgender children. It is for children with precocious puberty. And by the way, I have taken care of children of women who were on these drugs, who went on to have normal cycles and became fertile. So when they are saying that we are giving them chemicals that are causing permanent changes that are irreversible, these drugs are irreversible. Pubertal suppression drugs are reversible. The minute you stop it, they continue on with puberty. Did we delay puberty some? We did. They may have naturally started puberty at 11, and maybe we moved it over to 13 or 14. That is the extent of what has changed in their body, is when they started puberty. No different, by the way, than children who start puberty late. We call those late bloomers. So we just made them a late bloomer, but we gave them 1, 2, 3 years to be able to focus on their gender experience, work with their families, work with their pastors, work with their psychologists, psychiatrists, work on their mental health to know, is this where we're going?
Could you just talk a little bit more? You said that particular drug's been around for a while. What exactly is it used for, other than the cases we've been talking about mostly today?
Good. So, yes, this was brought up. This is a drug that we use for prostate cancer. That is correct. Why do we use it for prostate cancer? That's how it was first approved, by the way. Prostate cancer in men is fueled by testosterone. So what do? We give a drug that basically turns off those hormones so that the pituitary stops sending signals to the testicles to make testosterone, and testosterone is what fuels prostate cancer. So this is not a chemotherapy. This is not a poison drug. This is a drug that suppresses pubertal hormones, or in men, I wouldn't call it puberty anymore. We just call it our hormones. It suppresses it. And so this is why it's used in prostate cancer, but it's not a chemo drug. And it's why we use it also in children with early puberty who present with breast development and pubertal signs at age 3, 4, 5, 6, 7, 8. So we're using this primarily for other reasons, but it's the same drug for the same reason.
When folks, transgender people, come seeking this sort of treatment after this, they've gone through this process and are interested in pursuing this process, are you able to know, for people who are experiencing gender dysphoria, how many of them are experiencing that or have some sort of hormonal imbalance versus people who might have a normal, hormonal profile? Does that question make sense? Are there folks who are transgender and their hormones are kind of already out of whack versus someone who,
I wouldn't call it hormones out of whack. So there are some.
Yeah, sorry, that's not a
so there are
technical-
some conditions. For instance, there's a condition called congenital adrenal hyperplasia. These children are genetically female, and these adrenal hormones in utero acts like testosterone, and they are born with what looks like external male genitalia. They've got scrotums, a big, large clitoris that looks like a penis, and many of those children go on to either be lesbian, and in some cases even transgender, and there's a much higher risk of these children becoming adults who are lesbian or transgender. And the theory is that maybe these hormones are bathing the brain in utero during pregnancy and early childhood, and it's maybe somehow molding the brain to be more masculine, if you will. So there are some disorders, hormone disorders, that may make someone more likely to be gay or lesbian or transgender. But for the most part, these kids that we're seeing don't have these disorders. We have a few, like congenital adrenal hyperplasia, that I have taken care of. And it doesn't really change what we do. They still have this condition, this underlying condition that exposed them in utero and made them who they are, and we're not going to change who they are. We're providing this therapy to help their body become who they are internally, and that's how we're alleviating the dysphoria. Another thing I want to clarify is I keep hearing about castration, chemical castration, and so forth. All of these medicines we're using are no different than when we give a menstrual girl birth control pill, and we are making them temporarily infertile. When we're giving a girl Depo-Provera to make him infertile temporarily. When we give women with endometriosis, by the way, we use Lupron too, these pubertal blockers in those cases. It makes them infertile. A lot of these drugs we're already using in girls that make them infertile while they're on it. And when they go off of it, guess what? It all goes right back to normal. So during adolescent years, 12, 13, 14, all the way to 18, by putting them on these drugs, we are not causing anything that's permanently sterile. If they're on it less than 10 years and you stop it, everything is going to go right back to normal again. Now, if you've been on it for 20 years, there is now a higher risk of infertility. But at this point, they're now adults who are making the decision to continue these therapies. So these therapies do not, in childhood, make them permanently sterile. They make them temporarily sterile, just like we are giving many girls birth control pills or other forms of sterility. Second thing, we are not doing surgical sterilization in children in North Dakota. I've never referred a kid less than 18 for orchiectomy or hysterectomies in the state of North Dakota. So I think that's an important question. I was offended when I heard that we are coercing patients into therapies. And I want to make it very clear. We take the advice of psychologists, psychiatrists to tell us, these patients are meeting criteria for some kind of treatment. They come to see us. It doesn't mean we push these drugs on everybody. I have some kids, adolescents, who come to me and they might express that they are more non-binary or they don't feel male or female. There may not be a role for hormones in that case. And in fact, sometimes I say, you don't want to really be masculine. You don't want to be really feminine. I cannot target your hormones to be one or the other. Okay, it has to be one or the other. We can't have a combination of both. So many times we work on what else can we do to help, because hormone therapy, I don't think is the right answer, because you don't want to be really masculine. You don't want to be very feminine. So, we're not pushing the agenda. We are not pushing the treatment. We are listening to what they need and what they want, and we're trying to find the right fit. And it may be something to stop their periods, which causes dysphoria. It may be blocking facial hair by androgen blockers that are, again, reversible, because that's what distresses them the most, but they don't really, want breast development. So, everything is targeted for what they need. So we're not pushing one or the other. We're helping them to figure out what is it that is most important to you, and what can we do to alleviate your dysphoria, which is where hopefully the mental health helps there.
Could you just talk, I guess, a little bit to my question earlier to Courtney about, if the patient's a minor, what's the role of the parent in these discussions?
Exactly like what Dr. Dahl says. If they're a minor, they're incapable of consenting. They have to be part of the consent. In other words, we want their assent. They need to understand what the consequences of treatments might be, what's reversible, what's not reversible, and so forth. And we have a very long discussion. This is not when you go see your surgeon and they might have you sign a form and not read it. We are reading it. We are going through it and in detail. But yes, the parent has to be involved, and they have to sign a consent form that they're being aware of all the risks and benefits of our treatments. And the child also has to be involved in that consent, even though the legal one is really the parent. And one last statement. Do adolescents and adults who have gender dysphoria or transgender, do they still commit suicide? Yes. Sometimes it helps the dysphoria, but it does not take away the social stigmata of what it means to be transgender. You may remember a few years ago, Chairman Lee, I sent you an email about birth certificates in North Dakota. This was many years ago. I had a transgender child who was 17, had transitioned, and was happy with the transition. And his only thing is he wanted to go to Europe, and his birth certificate still read the wrong gender. And this was a big problem. And so it was a lot of and by the way, I stopped emailing you because the child committed suicide.
Oh, no.
Okay, he committed suicide, but it was not because of the transition. It was just all the other things that we have to keep in mind. You could be happy with your appearance now, but if you cannot go to the right bathroom, if you have to go to DMV and show a birth certificate that does not match your gender, if you cannot do these other things that society does not support you, this is a source of distress. It's not the gender appearance anymore. It's everything else that we are imposing on them. So that was just my last thing I really wanted to say.
Do I understand correctly, though, that the medications which are being taken are a lifetime medication?
No, not necessarily.
When do they end then?
It's up to them.
Okay.
It's up to them. Let me give you a perfect example.
Okay.
17-year-old I saw this week has fully transitioned, is very distressed about hair loss, losing a lot of hair because he's now male hormones.
Right.
And that is, we all get male pattern baldness. I don't love it either. I don't love it. We've tried, yes, we've tried some medicines to help block some of the hair loss, but that distresses him more than anything now. He knows he's virilized. He looks like a man.
Yeah.
He's got the voice. He got the Adam's apple. And ultimately, we decided we're stopping the testosterone, not because he doesn't feel. He says, the only thing I don't want to be is misgendered as a woman. And he says, no one is ever going to misgender me now. But I don't like the hair loss. And we are taking a pause from testosterone. And he knows that his periods are going to start again. He says, I have ways that I think we can maybe take care of that later on, but I will feel less distressed about having a period than I am about losing my hair. So we're stopping his testosterone, and he's going to have estrogen again. He's going to have periods, but you know what? He's going to look like a dude still, and he's very happy about that.
That's good.
So it is what you want. We work with what you want, and if that is what's making him happy, not having testosterone, but knowing he's virilized and he's going to have a period, he's okay with that because it's better than losing his hair, then we will work with that. Yes. So it's not for life. It's for what you want it to be.
Dan Sturgill, parent involvement is very important throughout the process. The first time that I would meet with a family, I would meet with the parents and the child together for that first hour. I would, give information about what we're going to do, go into another part of that evaluation where follow-up appointments, would likely be with the youth, that I would continue to be checking in with the parents about what they're experiencing with them, either before or after the session, making phone calls, those kinds of things, checking in with other mental health providers that are involved. And then there's a time when I would meet with the parents separately and say, hey, this is kind of what we found, check in with them on if there's any inconsistencies in terms of that. I'm also during that time actually evaluating the parents, because one of the things that we want to be really careful of is making sure that we don't have a situation where the parents have an agenda, or the parents are trying to solve some problem that could be solved differently. So parents are involved at the beginning, the middle, and the end. They're part of the evaluation. They're part of of what's being evaluated. And then at the end, there's some joint decision-making about me sharing, hey, these are the things that look like care would be positive. These are the things that we would caution. And then, the family makes the decision about what to do next. And then it would go on to endocrinology where they would, be having some similar kinds of checking in on that. But we would have a lot of that done before that endocrinology appointment.
I'm a board certified OBGYN. As part of my practice as an OB, I do provide gender affirming care for patients. Most of that care is medications, but for patients who are transgender men, I will do hysterectomies, which is removal of the uterus and potentially removal of the ovaries. And those are surgeries I only do in people over the age of 18. I do have a small group of patients under the age of 18, mostly older adolescents, that I manage hormones along with mental health professionals. My practice is similar to theirs in that I don't, even for adults, do this care without some mental health professionals. My testimony is more in discussion about detransitioning. With any procedure we do, with any treatment we do in any area of medicine, there is always this risk of regret or this desire to stop treatment. We know that detransition does happen, and as medical providers of this care, we want to make sure that we are ready to manage this as well. It's completely essential that we continue to work closely with our patients, that we don't abandon them, that we keep being a safe place for them to come if they desire to stop or pause their treatment. I'm going to kind of discuss a couple studies that have done about detransitioning, both for adults and adolescents. So there was a study completed from 1972 to 2015 in Amsterdam that looked at 6,793 patients. And they looked at this group of patients, 70% started gender affirming medication, and this was adults. And of those people who started medication, about 78% also underwent surgery. The rate of regret for trans women was 0.6%, and the rate of regret for trans men was 0.3%. So really, really low numbers. They kind of broke those numbers down further. So of those people, seven people total had true regret, whereas the rest were related to social acceptance issues, and then 2 felt they were more non-binary. There was also another study out of Spain that looked at almost 800 patients from 2008 to 2018, and of those almost 800 patients, only 8 detransitioned, so that would be about 1%. Here in the US, they did a study that looked at regret and desire for detransition, and that looked at 27,715 people. Of those, 8% reported either temporarily or permanently detransitioning. The vast majority of these were for what we consider social issues. So the biggest percentage was from parental pressure. That was 36% of people felt pressure from their parents was the reason they stopped. For some, that process was just too difficult. That was 33%. A large percentage reported harassment and discrimination caused them to either stop or pause treatment. And then concerns about getting a job was 26%. These patients still considered themselves transgender, but stopped due to other reasons. Other reasons that other studies have shown would be maybe cost of medications, medication shortages. I know for a little while I had a couple patients who couldn't get estrogen because of a shortage, including a cisgender patient who was on estrogen for premature menopause. She actually could not get her medication because there was a shortage. Some people are really happy with some changes, but not others. They're really excited about their voice deepening, but they're not super excited about having facial hair or body hair. So they may stop because they're happy with where things are at. And then there are some people who are unable to access safe care, and so they stop medications because of that. There are also a few medical issues that potentially cause people to stop the hormonal medications. Regarding adolescents and detransitioning, there was a very large study done out of Amsterdam with their protocols, which are very similar to the US protocols. They looked at 1,700 adolescents. If they presented to the clinic earlier than age 10, and it didn't necessarily start treatment that early, they just presented to the clinic, about half ended up on puberty blockers. If they presented to the clinic after age 10, about 2/3 of those patients started puberty blockers. Once they started those, only 1.4% of people stopped the puberty blockers. And most of those were because their gender dysphoria had resolved. So the clinic worked exactly how it was supposed to. We gave these adolescents a pause on puberty to kind of work through their gender dysphoria, work through any other issues, and gave them time, and then they stopped, and then puberty was able to proceed as normal. Kind of comparing these treatments and like these percentages and stuff to my area of specialty as an OBGYN, we perform sterilization on women. We remove their fallopian tubes. That's usually how it's done these days. This is absolutely irreversible. I always tell patients, I can't give you a fallopian tube transplant. I can't grow you a new fallopian tube. They're gone. Your ability to get pregnant is gone. I usually see them for 1, 2, maybe 3 visits before their surgery, and then probably 1 or 2 after. And their rate of regret is anywhere between 1 and 26%. So a pretty wide range. For vasectomy, the risk risk of regret is around 6%. And then for hysterectomy, which we commonly use to treat heavy bleeding, pelvic pain, endometriosis, the rate of regret is between 7 and 13%. So we're looking at, if you look across these studies, 0.3% up to 8% versus a hysterectomy, which is permanent, is 7 to 13. And these rates of regret for the gender affirming care studies are for hormonal treatment, not surgeries. There's much more follow-up involved and pre-treatment visits involved in gender affirming care than there are for these surgeries that I perform routinely. And there's much more follow-up after these surgeries compared to the surgeries for the gender affirming care. So I think we really work hard to make sure that we're doing all this counseling, we're working as a team, and we're doing the right things by these patients. And if they change their mind, if they decide to detransition or stop medications, we want to make sure that we're there for them in that situation too, and giving them all the support we can. Again, working as a team with mental health. And just kind of to reiterate, gender affirming genital surgeries, they're not done on anyone under the age of 18. I can't strongly recommend enough a do not pass on this bill. I think it's important to send a message to people who are transgender and gender diverse in our state that they're valued and that they're important in our communities and that they matter. I think our care is very thoughtful. It's very comprehensive, and I think it's very safe care.
How do the families respond? I mean, it's got to be challenging for the parents as well as a child for this whole situation. So is acceptance kind of gradual? Does it come? I hope that it eventually comes for, all families, but at least for most, because that would have to be terribly disturbing, I would think, for the child, even as an adult, that they were rejected by their families, obviously.
When I have a patient who comes in who is coming to me for gender affirming care, if they have their family support, and even better, if their family is with them, I mean, that makes me so happy. I feel so like, okay, they have this family support. Like, we don't have to worry about that aspect of things. It's really hard when they come in and they don't have support. And I'll say my population is mostly adult patients, but I have had some adult patients who don't talk to their families, whose families don't support them. And it's really hard on them. And we talk about it almost every visit. And I just kind of say, how are things with your family? Is there any updates, any change? And sometimes there's progress and there becomes acceptance and they repair that relationship. And sometimes there's not. And it's definitely really hard to see. And I think I just try my best to support these patients and keep my office a safe space for them, whatever they're going through. If I have a patient under 18 whose parents don't agree with the care and stuff like that, of course, we're not going to prescribe those medications. And I feel like my role in that is to continue working with them and their mental health care team. And again, my office is a safe space. So like, what can we do to alleviate your dysphoria, even though we can't do testosterone? Maybe we can give you medications to stop your period that are acceptable to you. And that at least lets them relieve some of their dysphoria.
My name's Dr. Mason Bedient. I'm a family medicine physician practicing in Fargo. I've been providing gender-affirming care as well as general primary care for the past 5 years. My colleagues have already given you a lot of information on the science of the care that we provide, but I want to speak briefly about the point of view of a primary care physician, someone who gets to take care of the whole patient over the span of a lifetime. I get to have a special relationship with my patients, getting to know both patients and their families in a way that many specialists don't get the opportunity to know them. Because of that relationship, I may be the first medical professional with whom a patient feels comfortable discussing gender identity, either their own or that of their child. I'm the one that they'll look to for guidance, and it's critical that I'm able to help them in a way that is best for that patient and that family. The key here is helping, not directing. I'm not the only voice in the room, and that's something we all bear in mind when dealing with transgender youths and their families. I've spent many appointments sitting with an adolescent and their parents, answering questions and addressing concerns from both sides. What if I do, as well as what if I don't? As a physician, I'll sit with that family as long as it takes to reach a consensus on the next best steps. The patient and their parents always get a say. We're not assisting in transition without consent from both of those parties. In primary care, we also deal quite a bit with the care of mental health disorders, particularly anxiety and depression. While it's not uncommon for transgender patients to suffer from these things, anxiety disorders and major depression are very different diagnoses than gender dysphoria, and each individual diagnosis must be treated appropriately in order for the patient to feel better. Gender dysphoria will not be alleviated with antidepressants. It is a problem with the physical body and therefore must be treated with a medication that will change the physical traits that are causing the dysphoria. By the same token, depression in a cisgender person would not be solved with hormonal treatment. I've personally been in that position, trying to treat my own gender dysphoria with antidepressants, hoping it goes away, and I can tell you that it does not work. You trust in your doctor to know the difference between a cold virus and a bacterial infection and treat either of those appropriately, so trust us to be confident in the difference between gender dysphoria and depression as well. It is also important to realize how access to care would be affected by passage of bills such as this one, not only for transgender patients, but for all patients. The majority of my practice is general family medicine for all people. Bills like this certainly play a role in determining where doctors want to practice, for me personally and for many physicians across the country. When the government inserts itself into the doctor-patient relationship, it's a red flag to many providers, who may then decide to practice elsewhere, which would deprive all patients of their care. Thank you for listening to the doctor who cares for the whole family and the whole community. I urge you to give a do not pass to HB 1254